Thank you so much for joining us today for the webinar 10 Years Clinical Application of Cerabone, Why, When and How. We would like to thank Dr. Damir Jelušić for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself, Damir Jelušić.
Hello, ladies and gentlemen, dear colleagues, good afternoon, good morning or good evening from Opatija, from Croatia. We are now live in webinar which is dedicated to Cerabone, to biomaterial, which is, I will say, in my clinic the most important and material which I used, and material which I use for more than 10 years. For those who doesn't know where is Croatia, a short review of European map, and with red dot you can see where is Croatia, where is Opatija, my place where I work and where I live. It's a small touristic place on the Adriatic coast, and here is also greetings from my dental clinic, where I'm a surgeon, master surgeon and master clinician, and where I perform all surgeries in a field of dental implantology and guided bone regeneration. Yes, guided bone regeneration, which we are speaking today about, it's a very large topic. Topic which is known for many years, and it's still actual and very, very dynamic. Lot of materials, lot of techniques, lot of protocols. But in the end, every clinician should know the right indication and to answer on most important questions: why, when, and how. So, speaking about GBR and why we are doing GBR, first of all, it's the first answer is to reconstruct deficient ridge, to reconstruct deficient bone, to create a new bone. If you look at this X-ray, you can see lateral maxilla, which is very resorbed. On the right-hand side, absolutely very thin ridge of few millimeters. On left-hand side, there are two islands, let's say, on the mesial and distal part, which maybe can be used only also with some another technique, not only by sinus lift, meaning lateral window approach. Why? To reconstruct deficient ridge. This is a case with extreme thin ridge. The patient with oligodontia, meaning that there is, to this young lady, there is missing more than 6 permanent teeth, in their case 8 permanent teeth. Very thin ridge, very difficult case, and of course today bridges, classical bridges anchored on 2 neighboring teeth are not an option, not a valid option. So we have possibility, we have knowledge, we have techniques to face this case in another way, to reconstruct the ridge, to place later on implants, and to restore this young lady in a most natural way. And this is with single tooth, with single crowns on implants, for example. We use biomaterials, we use membranes to prevent soft and hard tissue collapse. Why? To have most convenient shape of ridge where we reconstruct and where we are doing our reconstructions. This should not be only the implant reconstruction. This should be this could be also classical bridge with ovoid pontics, for example. This is a case with 2 fractures in the 2 central incisors. Also, young lady, you can see the absence of a vestibular buccal bone, the treatment of alveola in with biomaterials, filling the alveolus with biomaterials, socket preservation, and you can see result 4 months later. If we compare this line at the beginning and the final result, you can see that the same line match to both sides on the pre-op and post-op situation, meaning that with socket preservation, with our procedures where some biomaterials is placed into alveola, compacted and stabilized, we preserve soft tissue. We preserve also hard tissue. So we create a very nice and very comfort situation for the future implant placement. Sometimes we also preserve a ridge, the whole ridge, not only one or two alveolus. Here is a case with 6 implants with multiple extractions where all extraction sites are preserved with Cerabone. These white granules are granules from Cerabone, and also all gaps between bone and implants are also filled with Cerabone. Why Cerabone? Because Cerabone is very, very stable material. Cerabone will never lose the volume, and Cerabone will never ever completely resorb. This gives us guarantee to have a long-term result, to have a completely predictable and stable result on our restorations. In some cases, we correct also with biomaterial soft tissue profile. This can be done this can be done also with connective tissue graft, but it also can be done with some bone substitute material. Here, in this case, it's absolutely not necessary to build a new bone to reconstruct the bone, because implant is surrounded with more than 2 millimeters of a bone all around. But to create a nice result, to create aesthetic result, it's necessary to give some bulky profile on this premolar, and this is very efficient way, very traumatic way to do it in the same time during the implant placement. And on the right hand side, you can see the final result with a single crown on implant and no concavity, as you can see on initial situation. Implants are today most important, let's say, topic in many dental practices, and GBR is always connected with implant placement. So why we are doing GBR in most of the cases? To place implants. To place implants in a prosthetic-driven position, meaning that the time of implant positioning where the bone is, it's past. We try to place implants where the tooth should be reconstructed, and if there is no bone to place implant in such a way, in such a position, we start with GBR procedures to reconstruct the bone, and later on or simultaneously we place implants in the right position. You can see here a lot of molar, a lot of implants in a maxilla, where some of them are done with the sinus lift, with the classical approach, a lateral window approach. Some of them are placed with Summers technique, with ostome technique, which is very, very simple and also safe and less traumatic for the patient. Most of the implants are single implants for single crowns, and on the left hand side you can see 2 implants for a small span bridge with 1 cantilever, just to avoid the necessity for lateral window approach and for sinus lift. But when we are dealing with full arches, with full arch reconstruction in maxilla and also in mandible, then we need implants more or less in important strategic positions. The weakest point usually is always lateral maxilla, where is sinus, where there is a need to proceed with sinus lifts to have a nice support for implant placement. You can see here bilateral sinus lifts, and in the middle with these signs, you can see between every implant one sign which show you the preservation of alveola. So during the same surgery, bilateral sinus lift, extraction of a teeth, implant placement, and reconstruction, preservation of a whole ridge using biomaterials, which is again very stable, which will give us the long-term stability, or let's say lifetime stability in a sense of volume, etc. Strategic positions could be also achieved in different ways. Every patient is different. Every indication is different. Here it's one concept which is based on 4 implants in a frontal region, just for immediate loading. But as the implants are quite mesially positioned at the position of canines due to the anatomy of the patient, on the left-hand side there is a sinus lift, classical approach, lateral window approach, and on the right-hand side it's implant position in a septum with a transalveolar approach, just to make our life easier, and also the trauma for the patient, but always keeping in mind the predictability of treatment and the end result. So, when? Of course, when we ask such a question, the answer is always or before implant placement, or simultaneously with implant placement, or after implant placement. This is a universal answer to the question when. But entering into the details, we can say that there are a lot of techniques which can be performed before implant placement. Such techniques are socket repair or socket preservation, sinus lift, horizontal GBR or vertical GBR. All those techniques means that first we try to reconstruct the bone, and after 4-6 months we re-enter into the site to place implants. What are the advantages of such stage approach? Of course, it's slower. This is not an advantage, but it's safer. It's safer because we go step by step. So in every step, every future step, when, for example, implants are placed, we can correct something from a previous step. So if someone is not very experienced, if some clinician would like to go more on a safe side, then step approaches to consider and to recommend. For those more experienced and skillful, the most used approach is simultaneously approach. So implant placement with some kind of bone regeneration. This is immediate implant placement in the post-extraction sites. We will see few cases on this topic. Treatment of fenestrations, treatment of deficiencies, sinus grafting, and again, horizontal GBR and vertical GBR. You can notice that many of those techniques can be done simultaneously or can be done before implant placement. So it's a question of clinician choice, what to do, and at the end of situation and right indication when we can go simultaneously or not. And what we treat after the implants are placed. This is, dear colleagues, management of complications. Today I will not speak about complications. I will just show you these three pictures of periimplantitis, where the implant was absolutely indicated to extract, to explant, but the old lady prayed me to leave the implant, and I listened to her, and then I did step approach, removal of prosthetic crown, then healing, then cleaning with everything possible, GBR around the implant, and you can see the result after 3 months, 3 or 4 months, I don't remember, where the complete bone is regenerated and the same crown is fixed on the same implant, and that's this procedure I did maybe 1 year and a half. So it's 1 year and a half where is the same crown in a patient mouth under the load, even though the implants was completely surrounded by with inflammation. So let's go on and try to respond to these important questions, and at the end say how we should do the GBR, and what are the factors which are influencing all the procedure, and at the end success procedure, and in the end success treatment and satisfied patient. We need few things. It's like a chain. We need few rings, and you can account them from the top or from the bottom. It's always the same because all those rings are very important. We need bone substitute and membrane. We need surgery technique and right protocol. We need right indication, somehow indication matrix or patient selection. So when all those rings are connected together, we can obtain a nice result, we can have success, and we can have a very satisfied patient. Regarding biomaterials, I will not go in detail. We divide biomaterial in bone substitutes and autogenous bone. We are speaking about bone substitutes. From those bone substitutes, there are biological, synthetic, but Cerabone is a xenograft. It's from animal origin. It's osteoconductive biomaterials, means that it's completely inert. Regarding membranes, absolutely the most popular one is collagen membrane, resorbable membrane, and the majority of GBR protocols are done with resorbable collagen membrane and with xenografts. In the terms of materials and the Botiss portfolio, I should say that Botiss has complete range of biomaterials, complete range of membranes, so every clinician can feel completely and safe and confident with the Botiss company, and can find the most suitable material for every single case. So the whole webinar is dedicated to, let's say, celebrate 10 years of clinical use of Cerabone. And I should say that I really am proud to belong at this small group of doctors which started from early beginning using Cerabone 10 years ago. And today I'm still with Cerabone. I don't have any other material. I have other materials from Botiss, but the Cerabone is the most important one and the most universal one. This is the main characteristic of Cerabone. It's pure biologic bone apatite, treated at 1200 degrees centigrade. It's highly porous, with rough surface and with slow resorption. I would say this slow resorption is really slow, and some of the particles will remain in a patient's body forever. And this is everything scientifically proved. Cerabone has macroporosity, microporosity, and nanoporosity or nanostructure. What does it mean, macroporosity? Macroporosity means rapid vascularization, meaning the stabilization with blood clot. Microporosity means ingrowth of cells, and nanostructure means the ingrowth adhesion of molecules, of cells, of proteins, of growth factors. Mean pore size is 600 to 900 microns. There are interconnected pores at the end. The structure of Cerabone is very, very nice for adhesion of a cell and for ingrowth of proliferation of osteoblast. And you can see here that there is a really huge proliferation in a 7-day period. Cerabone has preclinical, clinical, medium and long-term studies, so it's well approved, it's well documented, and really this is a very nice material which I personally use, which all of you can use in your offices. But the main characteristic is stability and completely inert characteristic, which give the chance to ingrowth of cells, of capillaries, and soft tissue, which are then transformed in a newly formed bone and then in a mature bone. Let's speak about clinical side and clinical cases. You will see a lot of clinical cases and a lot of indications which are covered with Cerabone, and some of them are for many years very stable in a patient's mouth. So the main classification of defects is the post-extraction defects, post-extraction sites, dehiscencies and fenestrations, sinuses, sinus grafting, and horizontal and vertical bone defects and horizontal and vertical bone regeneration. This is, of course, the most difficult one. From each topic, we can speak a lot of hours, not a few minutes. I will try to give you an overview through my clinical experience, through my clinical practice. I really have protocols which are proved, which are developed, which are in use for many years, and some of them I will show and share with you. So maybe there is some new thing, there is maybe some small tips or tricks which can be useful for you in your office, in your practice. Socket defect box post-extraction defects are defects, the most common defects, let's say, present every day in our offices, in frontal, in lateral region, in upper, in lower jaw, single or multiple but we are dealing with extraction sites every day. What can we do and how we can manage the extraction site? The first choice or the first dilemma is to place implants in the same time or go to delay procedure. If we would like to go slowly, sometimes the patient like that clinician goes slowly, not very fast. The first and the most easiest and most simple procedure is socket preservation, meaning filling of alveola, of cleaned empty alveola with particles of bone substitute. You can see Cerabone particles, big granulation size from 1 to 2 millimeters, and those particles are covered with collagen fleece. This is a Jason fleece. This is a natural collagen, twisted as a bilayer collagen sponge, and then just stabilized with the suture. The aim of a collagen sponge is not to protect the alveola for 4 months like a membrane. It's just to stabilize, to help the stabilization of particles in the first 2 weeks, and after start the natural healing as in every empty alveola, but with one very important advantage, and this is the more rapid bone formation and prevention of bone resorption and retraction of tissues, the hard and soft tissue, bone and the mucosa around. After 4 months, this is my standard healing time for preservation of alveola. After 4 months, you can see nice mucosa. You can, on the X-ray, you can see Cerabone particles. Those Cerabone particles will be always there. They will never disappear completely, and implants is placed in this preserved, the newly formed bone, and you can see the final implant with the crown and the abutment. Everything stable and everything straightforward as a procedure. One short reminder regarding extraction and alveola, preservation of alveola. Here is a case where the position 1-1 is filled with Cerabone, so the standard socket preservation. On a position 2-2, there is just a collagen sponge without any bone substitute. So this is a standard procedure, Cerabone with Jason fleece, with collagen, and this is 4 months later, where one position 1-1, it's sorry for error, it's 1-1, it's preserved, 2-1, it's spontaneous healing, and from the external view, everything is the same. The ridge is maintained, but looking the X-ray, you can see socket repair in a position 1-1 with nice maintenance of a most crestal part of a ridge, and on a 2-1 position, you can see the outer line, which is mucosa, which is nice like in the previous slide, but looking the bone formation and the bone structure, you can see complete resorption of a buccal bone, complete retraction of a ridge, and this means that if we would like to place implant, there is a huge difference between sites which are preserved and sites which are not preserved. Let's go on a clinical case of 2 incisors which are with apicectomies, which are indicated for extraction. X-ray is not very promising, CBCT is not very promising. The soft tissue are quite nice, even they are quite with a lot of scars, but this is not so important. The most important effect is the absence of a buccal bone wall, and in such a case, membrane, not anymore Jason fleece, is placed on a buccal side, then Cerabone under knee of a membrane, and everything is protected, but with Jason fleece, just to protect the early exposure of a collagen membrane. Post-op situation is quite clear. Everything filled and compacted with Cerabone and stabilized with fleece and sutures. After 4 months, you can see more or less the same volume of previous roots. So the ridge is preserved. You can see some particles of Cerabone, and this allows me to go directly into the implant placement. X-ray before and after. So before bone preservation and extraction, and after the 4 months before the implant placement. So implants are placed in such positions where you can see a lot of Cerabone, a lot of regenerated bone, but we don't know is it regenerated or not, because we cannot judge and evaluate the histological findings, but seems good on a CBCT, and clinically ridge, flapless technique with punch. After integration of implants, development of individual emergence profile, and the final restorations with 2 single crowns. Pseudopapilla between 2 crowns, papilla in a distal region, in a distal segment of incisors. And what you can see here, it's very interesting. You can see post-op, you can see 2-year, 4-year, and 5-year X-ray, and no difference on a marginal bone. Very stable situation from aesthetical point of view, from a healthy point of view, no inflammation, and just one difference, and this is in a 5th year, the new abutment because due to fracture of zirconia abutment on a position 2-1. So Cerabone remained there, and it's completely transformed in a bone. Here is another case with fracture of a premolar, first premolar on the right side, with very small ridge and all roots prominent into the sinus. So with small ridge, what was my choice? To preserve at least few millimeters of this small ridge. The way how to preserve is socket preservation with Cerabone, with Jason fleece, and after 4 months, transalveolar approach to create a new bone formation into the sinus for another few millimeters, and this is development of emergence profile, final crown, and we can only say that it's completely natural. But the most important slide is this one, where you can see on the left side the preserved ridge with few millimeters of let's say 3 to 4 millimeters of residual ridge, and transalveolar approach with Cerabone and implant of 8 millimeters, so let's say 4 plus 4, and adaptation and regeneration of a Cerabone around the apex of the implant, where you can see the complete, very nice and integration of particles and surrounding bone. So with small steps you can do a lot for a patient. You can be very gentle and you can obtain very nice results. Here is one similar case with position 2-1, where no vestibular bone is there, And here I place this case just to show better the technique how to preserve bone with the absence of a vestibular bone wall. So the membrane, under the membrane, Cerabone particles, well compacted, stabilization of membrane, and protection of the membrane with Jason fleece. After 4 months, from a situation where there is no buccal bone, there is only soft tissue on the root surface, to the situation with bone regeneration, with large ridge, with comfort situation for implant placement. And on the right side, implant with abutment and the crown. From single tooth replacement, I skip to bridges in the front. Here is a situation with 4 incisors. You can see fistula, granuloma. We did some attempt for endo, but without any success, fistula persisted. So at the end, I decided to solve a case with implants. Extraction of 4 incisors, cleaning of alveoli, and combination of Cerabone, big particles, and PRF to enhance the healing and to give a better chance for better healing. What I would like to show you and to emphasize is where and how to position the Cerabone and where and how to position the Jason fleece. It is very important to compact the Cerabone into alveola and to place Cerabone till the margin of a bone. Cerabone should not be in contact with gingiva or with mucosa. So the gingiva, the whole circumferences of alveola should be clean, and then the Jason fleece is placed in a contact with soft tissue. So let's say it's quite easy to remember. Hard tissue with hard tissue, soft tissue with soft tissue. So Cerabone in a contact with bone, Jason fleece or mucoderm or membrane in a contact with soft tissue. That's very important to obtain a nice healing and to obtain nice results. This is 2 weeks later. You can see some particles, some places where there is a healing per secundum. This is completely normal. And you can see X-rays, CBCT for every single root, for any single extraction site. So there are sites with granulomas, there are sites with no buccal bone, but in a lower row you can notice that there is no difference between maintained volume and situation after a healing period and after preservation of each alveola with Cerabone and Jason fleece. This is a ridge 4 months later. Very comfort situation to place implants. First drilling and indicator of direction, and this is a final bridge where you can notice very nice profile of a soft tissue, very nice architecture, surface, everything, and even bulky shape of front 4 teeth, and there is no difference between this bridge on 2 implants regarding a bridge on, for example, natural roots. Final result with X-rays. You can see Cerabone particles around. You can see Cerabone particles in a neighboring alveola, and you can see complete stability of marginal bone. Different sites and different, but the same approach. Molar region, 3 roots, implant placed in a prosthetic-driven position, so in the center, in a furcation area. A lot of defects around from a palatal side, from a palatal root, and from two buccal roots. Everything filled and compacted with Cerabone, and everything stabilized with Jason fleece. Again, Cerabone in a contact with bone till the connection between abutment and the implant, even a little bit more coronal, and the Jason fleece in a contact with soft tissue, and just stabilization of Jason fleece, no tension, just stabilization, as you see here. From after 4 months, the site is completely healed. You can see very little resorption and retraction of soft tissue, no changes on a buccal side as a shape of a ridge. Finals with shape with individual emergence profile, final crowns, and X-ray with 2 single crowns, and again a Cerabone around implant, Cerabone around a little bit around abutment. Of course, there is a soft tissue there is integrated into the soft tissue, as you see on the left side, but the most important characteristic and the feature is stability. So Cerabone means stability. Smaller case with defect on a vestibular side, Cerabone in a contact with bone, stabilization with Jason fleece, and you can see nice restoration, and you can see control, very nice gingiva, and also 2 years after, everything very healthy. Molar area, implant in a septa, Cerabone, Jason fleece abutment. 3 years later, completely stable situation, even with inflammation of a last molar, neighboring molar. So the procedure is really safe and you can be completely confident with this procedure. In the upper area, no buccal wall, let's say crater around the root, immediate implant placement on a far palatal side, so remain a lot of space under the soft tissue on the vestibular side to fill those spaces with Cerabone. Stabilization with Jason fleece, development of profile, and implants, single crowns on single implants, and also here nice situation, and even 1 year later, no retraction in the inter-implant area. Fenestrations are quite simple to treat if they are into the bone envelope, into the bone volume. This is a lateral incisor. You can see from a diagnostic that there is fenestration expected, and intraoperatively fenestration in a coron central part of implant, 1-stage surgery, and final restoration with very healthy tissues. The efficiencies are completely different regarding fenestrations. This is the defect on a core of cervical part of implant. You can see absence of a vestibular bone wall, repair of soft tissue with PRF, and after 2 months or 3 months, implant placement with bone regeneration. So Cerabone is placed directly on an implant. It's recommended to cover the surface of implant with bone chips. I didn't do it here. Membrane coverage, suturing, and you can see here the design of incision with only one releasing incision. Try to be as gentle as possible and to avoid as much as possible vertical releasing incisions. Horizontal and vertical still and more complex bone regeneration. This is a very old classic case with such a defect in an area. Cerabone, big particles, membrane with pin, stabilized with pin. Of course, you should always follow the rules for GBR, tension-free suturing. And this is 6 months post GBR, nice ridge and nice situation to place implant in a prosthetic-driven way. You can see rough surface of regenerated bone due to the big particle size. This is, let's say, a small disadvantage of Cerabone of 1 to 2 millimeters. Today I use only 1 to 2 millimeter. Small particles and big particles are reserved only for sinuses. And this is 8-year control of this GBR with implant. Similar case in a aesthetic zone, diagnostic, preparation of a flap, preparation for the implant placement, exposure of implant, regeneration with Cerabone. Do not exaggerate with Cerabone. Apical stabilization of membrane with pins. You can see how membrane is stable. On the palatal side, its coronal side is stabilized with a suture. And when everything is stable like this, you will absolutely have bone regeneration. But of course, you should suture in a tension-free way. Flap releasing, incision, periostal incision, and tension-free suturing. These are the most important, and these are the rules for a GBR, for horizontal GBR, and every single rule should be completely satisfied. Follow, if not, there will be no success. You will have exposure of a membrane and exposure of membrane and no success. And this is re-entry at 6 months, and you can see that there is a combination of new form bone and Cerabone on the vestibular side. But again, we would like to have Cerabone to maintain the wall. Here it's repositioning of mucosal flap and final contour, and you can see the quantity of regenerated bone on a vestibular side. So the implant is surrounded with more than 2 or 3 millimeters of bone. And my last topic today is sinus floor elevation. Sinus floor elevation, it's one of my favorite topics. And in common, it's divided in a transalveolar approach or classical lateral window approach, meaning the preparation of vestibular fenestra. Transalveolar approach is based on compacting and condensing and pushing the bone toward the sinus floor and fracturing the sinus floor with special instruments called osteotomes. Here, instead of osteotomes are used with a hammer, so it's necessary to tap during the preparation. One short schematic drawing. So from partial drilling, tapping, up fracture of sinus floor, biomaterial application, and then implant insertion. So we are approaching the sinus through the alveolar crest, And here are some of control, some of my cases. One is from 2010, and you can see control on 2000 of this year, 17. And if you compare the apical part, you can see how nice, compacted, and the bone is, and you can really ensure yourself that there is really bone. If we cannot say 100% because we need a biopsy to prove this. On a lower row, there is one premolar and one molar, also control of 2 years, and you can see that one single molar is restored on one single implant of that little bit larger diameter, but performing the transalveolar approach in this reduced ridge. How? So initial preparation for the positioning of implants in a prosthetic-driven way, osteotomes and hammer, a fracture of a wall, of a floor, and application of biomaterial. I usually place a biomaterial with osteotomes very gently, because you should not rupture, lacerate the Schneiderian membrane. The Schneiderian membrane should be intact. So this is the most important fact. You can see here the residual ridge, which is very thin. There is maybe 2 to 3 millimeters, and you can see all around Cerabone pushed into the sinus. And in this situation, implant is placed and stabilized. Usually, the stabilization of implant is not very difficult. If you have few millimeters, by the literature, you should have at least 4 millimeters. In reality, it can be done also with 3 millimeters, but you should have enough nice ridge in terms of dimension of vestibulo-oral dimension. Implants in situ, 3 implants in situ position in a way that there will be enough height for the abutment and for the soft tissue, and this is a case. So pre-op, post-op, and baseline after 4 months, where you can see also here that a single molar is restored on implant which is anchored on these few millimeters of bone, and everything else is regenerated bone around implant with Cerabone. Other procedure, other style, classical style of sinus grafting is sinus lift or lateral window approach. This can be done in 1 or 2 stage. 1 stage meaning that sinus floor elevation and implants are done in the same surgery. 2 stage meaning means that first it's a sinus floor elevation, so grafting, and after 6 months, more or less, is the implant placement. Here it's a 1 stage technique. You can see preparations for implants. You can see fenestration. You can see Cerabone in situ and implant in situ. Membrane coverage, and this is the final. This is the same case. So with this small amount of residual ridge, with 1 implant and sinus floor elevation, we can restore bridges, or we can restore single crowns, and we can account on this technique completely. I should say that my first indication to use Cerabone was a sinus lift 10 years ago, and I really have a very good experience. No inflammation, very nice handling, and everything very fine with Cerabone. It's really inert material. It is crystallinic with the touch with the instrument, but this is absolutely fine. when it's stabilized with the cloth, you can even suction. You can do suction around without any problem. This is sinus grafting for one single tooth restoration, so you can see the residual ridge and 5-year control, and also here you can see stability and very nice results. Very huge restoration. This is a colleague of us, not from a dental field, but a colleague in the medicine field. From this beginning situation, I did bilateral sinuses, 8 implants in the upper jaw. You can see what kind of resorption it is, and also quite similar situation in the lower jaw, but in the lower jaw without any kind of bone regeneration. And 5-year control, stability, and even with such a big restoration, you can see lateral X-ray to understand what kind of restoration it is. And you can see here in the middle the diagnostic wax up and the mask for understanding where will be the future dental rehabilitate and where it's the bone to understand what kind of rehabilitation to establish. At the end, one histology, 6 months after sinus floor elevation with Cerabone. What you can see a lot of new bone. You can see that the Cerabone particles are porous, that the new bone grow into those porosities, those interconnected pores. But there is very good osseous integration, high degree of osteoconductivity. New bone is formated on the surface, so we have a nanostructure, and also grows into the granules. During the time, there is a very little resorption of granules. I'm arriving at the end, dear colleagues. With Cerabone, there are more or less, even more, not less, than 6,500 successful clinical treatments, more than 70 scientific and clinical publications, and it's used in more than 90 countries. You can use Cerabone in all indications: sinus grafting, ridge augmentations, peri-implant defect, extraction sockets, bone defect, augmentations of any kind. This is everything scientifically proven. With this statement, I would like to thank you for your time, to thank you for your attention, and I would like to say hello from my clinic in Opatija, and if you have some questions, I will try to respond to them. So I have a question. Do you place Cerabone directly onto the surface of the implant? Yes. The question is yes. I said that in dehiscencies maybe it's better to approach the so-called sausage or sandwich technique with some particulated bone on the surface implant, but if it is better, but honestly, I'm not doing always like that, and in extraction side, I place it directly on the implant. How did you clean out and treat the implant surface in the example of peri-implantitis, where you burr the implant for the better bone formation? Yeah, I cleaned the implant surface with everything. So with chlorhexidine, with iodine, then I applied photodynamic therapy. I cleaned the surface with small, like interdental rotating brushes, and after, then I place again chlorhexidine, rinse with saline, and then I placed the biomaterial. Okay, I have more. Do you only place Cerabone during your socket preservation techniques? Do you only place? Do you not combine it with autogenous bone? No, no. I place only Cerabone. Only Cerabone. Exclusively, just Cerabone. I try always to minimize the suffering for the patient, and I try not to open the secondary field to harvest the bone. If I can scrape some autogenous bone around, then fine, but it is not my routine. Okay, whether this kind of bone substitute is suitable for periodontal regeneration as well, such as mandibular molar with furca 2 defect. Okay. I will say my clinical approach as a periodontist. I do not treat furcas with biomaterial. I just use M-dogain as to enhance the healing. So in a furca defects, no biomaterial in my clinic. Okay, there is. Okay, someone said thank you. Okay, thank you very much again, and have a nice evening, morning, afternoon, whatever, and hello from Croatia.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.